There were a lot of things going on, obviously, at the annual meeting, and Steffi Woolhandler and David Himmelstein updated their massive set of slides to start off the thing. And there was a panel discussion with Stephanie Kim, who is Pramila Jayapal's health policy person in Washington, D.C., who was part of that panel and did a great job.
He was great.
Yeah, that's all that happened on Friday. Saturday, several sessions. I put together some snippets from Path Forward, but throughout there was the theme, and also I attended the board meeting on Sunday, which reiterated a lot of the controversies within PNHP. I just listed a few of them here, and I think we can talk about those tonight. Working on state-based, quote, single payer versus only national, the place for incremental, if any, and in the single payer movement, working in coalitions, various public options. Were the elections a referendum on single payer or not? Finally, the path forward with Biden and the Senate. So I was thinking that we'd start off, show the first section of that final panel discussion. Then we can stop there and talk about that particular issue that was talked about, and then move on to the next one first. So this is Claudia Fagan, who's a PNHP organizer out of Chicago and has been around forever. She's like the head of Cook County Hospital in Chicago, still working, as a PNHP organizer and on her job there. And she's in a couple other positions there in Chicago, working on health policy. So she was the moderator of this last panel. So first topic was how single payer advocates can respond to incremental proposals.
Welcome, Susan.
Thank you so much, Dr. Fagan. I'm glad to be here and part of.
And this is Susan Rogers, who's just after this meeting took over as the national president of PNHP from Adam Gaffney, who was in the position for 2 years. It's a 2-year position.
There, we're glad to have you. So next I'd like to introduce Rachel Medley, who is in her fourth year of her PhD training at Columbia University, where she studied microbiology and immunology. She became involved with healthcare activism after noticing the gap between the development of new medications in a lab and the delivery to patients who desperately need it. She serves as the student board member on the PNHP New York Metro chapter and is an executive board member of Students for a National Health Program, where she worked to expand the base of support for Medicare for All and to other health professionals. And last year, Rachel published an op-ed in the New York Times. Welcome, Rachel.
Thank you so much. I'm very excited to be here with you.
Okay, great. And Adam Gaffney, who you met earlier, is our current president of Physicians for a National Health Program, and he helped to lead working groups that developed PNHP's position proposal for single-payer healthcare reform and prescription for reform of our broken pharmaceutical system. He is a pulmonary specialist at Cambridge Health Alliance and an instructor at Harvard Medical School. Adam has written dozens of articles for both scientific journals and mainstream news outlets. And his book, To Heal Humankind, The Right to Health in History, was published in July of 2017. Adam, we're glad to have you, and I think that this will be a good discussion. So I'd like to start off by giving each of, we're going to talk about the path forward. And, maybe if you could, we want to talk about how single payer advocates can respond to incremental proposals like the public option or lowering the Medicare eligibility age. So maybe if we start with whoever wants to take that question first.
My personal feeling is that the way we get to Medicare for All is, of course, advocating and pushing for Medicare for All. But I don't actually think that there's a trade-off between pushing for Medicare for All and actually achieving some incremental improvements along the way. If you look at, the social movements in history, they rarely achieved everything they wanted right away, but they pushed for the gold standard. They pushed for true equality, and they won major achievements along the way, but they didn't do that by sort of lowering their standards or shooting for something lower. So I do think that the way we change the discussion, the way we have changed the discussion is through Medicare for All advocacy. And I think even if you look back over the last 5 years, even though Medicare for All was really not in the cards politically, certainly not during the Trump administration, certainly not even during the Obama administration. But by pushing for Medicare for All, we actually saw the incremental proposals actually sort of get somewhat more progressive as those who supported those kinds of solutions realized that they actually had to come closer to where we were. So I guess I would just say that whatever you feel about the potential benefits of some of these incremental sorts of proposals, I don't even think that we sort of are more likely to get them by lowering our sights. I think we're more likely to get some incremental solutions in the meanwhile by pushing for Medicare for All. And I also know we're not going to ever get to Medicare for All unless we really keep our eye on the prize.
Yes, I will add to that. And I think it's important that if we do incremental approaches that we don't add to the issues that we already face. And that's one of the things that a public option would do, is that it still puts fuel on the fire that supports the use of private insurance companies, which is another barrier to healthcare. And that made the public option clearly will add a few more people to those who need healthcare access, but it doesn't decrease the per capita cost because it continues the whole private insurance coverage system that we have, which is so profit driven. But I think one of the core issues in this country that we have to acknowledge is that this country never wanted equality. This country has always allocated resources that were guided and dictated by the structural racism that this country was founded on. And we can't separate the need for providing health care from all the other social justice issues that impact health, like housing, food deserts, well-resourced education, and others. Now, some critics will argue against Medicare for All, saying that they argue the need for choice and that we can't have one size that fits all. But when you think about it, we do need one size that fits all because we don't know what our healthcare needs are. We may know what they are today. We know what they aren't today, but we don't know what they will be this afternoon, what they will be tomorrow, what they will be next year. So we all need coverage for all unexpected and expected medical needs. That's the underlying need for insurance, to protect us from the unexpected. And by saying that we would all benefit from equality, from the same coverage, flies in the face of equality. We need everybody to be covered for everything, and that would make everything equal. And so there's a lot of resistance because of the structural inequality that this country has been built on. And one of the things the pandemic showed was really highlighted and made quite visible the need for healthcare access, and highlighted the need for healthcare in general for everybody. And it's made an impact on many who thought they would never have issues accessing healthcare. So there are multiple challenges ahead, and we have to debunk the myth that everything in this country is better than everywhere else, including our healthcare system, because it clearly is not. And we still have to make sure within our a single payer health system that we maintain control over the infrastructure so that it doesn't create poorly resourced neighborhoods and poor communities, similar to what has happened with public education. We have to make sure that all hospitals welcome all patients. We have environments now where you have a very wealthy hospital that is not welcoming to the poor communities that are right across the street. So now is the time not to let up on this fight, and now is the time to really continue and forge ahead.
Basically, the first thing to talk about is, the role of single payer advocates and incremental proposals. And I think there's kind of two voices there. One is that we should always keep our eyes on the prize and always put single payer out there, but others say there's some incremental things that are worth doing because they take us on the road, and as long as they don't increase the role of private insurance or decrease the role of private insurance like some of the so-called public options may do, then it's something we need to look at. Thoughts about single payer advocates working on incremental proposals? And
Let me just,
there are
one of the reasons I joined your organization was I've been active in PNHP for 10 years in Nevada. I took 3 years off after I came up here to finish my career at Jefferson, but I did set up and run a free clinic in 2010 for a Volunteers in Medicine organization down in Las Vegas prior to the Affordable Care Act being initiated. And I really think, unfortunately, as a devout follower of single payer and the mother of a disabled adult who prior to 2010 was unable to be insured at any cost, I will say that right now, I think with the money and the focus on the general public on the coronavirus epidemic and just the division in the country, I think that the game is going to have to be incremental. There's no way that if we go full bore towards single payer and no other option, that I think after 40 years in primary care internal medicine, that the public is going to go for it. I think it will torpedo our organization and our movement. I think that the game has to be, as Adam said, keep your eye on the prize and do whatever you need to do to work forward. And there's some concrete things that have been floated out there that we could do.
Anybody feel free to speak up. I was going to say there's one thing that may be considered incremental that's out there now because of the pandemic is the Healthcare Guarantee Act and some other programs that provide pandemic care under Medicare. So a lot of people at the annual meeting in the board meeting on Sunday said that they always kept throwing out the, you can't put the toothpaste back in the tooth thing. So if people get a taste of Medicare because it's covering their pandemic needs, when the time comes for the government or whoever to take that away from them, they're going to be very pissed off about it.
Well, pre-existing condition thing, and Dr. Murray can speak to this too, what little coverage there is for mental health, both pediatric and adult. People are not going to turn, or for addiction medicine, for God's sakes. I mean, you can't take that away now that the general public knows it's out there. They're not going to go for it. But yet, people who are anti-single payer, they offer no options. So we have to take advantage of that and keep pushing on that they offer no options. They just complain.
I have a slightly different take on it as one who is on the Universal Healthcare Work Group here in the state of Washington, something that is a government-sponsored work group tasked with coming up with a plan to get to universal health coverage in Washington state. One of the things you have to deal with is that hopefully this group will come up with working towards a completely public plan where the state runs it and everybody's included. But you can't just do that overnight. And meanwhile, there are people who are hurting. So we're going to need to do some short-term fixes to the Affordable Care Act and how it plays out in our state to help some groups that are really hurting while we work on the infrastructure that's needed to transform the system over a period of 3 or 4 years to a state-run single payer. Now that's that focus. Now in joining that as a representative of PNHP, which is how I got to be on the work group, it's looking at Washington State as the Saskatchewan of the US. As you all probably know, Saskatchewan put in a public health hospital payment system in 1947, and then extended it to physician services in 1961. And the rest of Canada looked over the edges and said, ooh, we like that. And pretty soon there were different plans in every province, followed by an overarching federal system. So what keeps me going in working with the Universal Healthcare Work Group in our state is the idea that even if things are not moving the way we want them to in Washington, we could put in place something in our state. Now, that said, you can't do it in any state without at least cooperation from the federal government, because there is so much federal money involved that comes into our state. You have to get our state's hands into that and pull it into a state system, or it's unaffordable. So the hope is that the incoming administration will be more friendly toward the idea of a state experimenting with this at the same time that they can sort of diss off Medicare for all for now. We could try a system in our state with federal cooperation that would bundle all that federal money and put it into our state system within a couple of years. Anyway, that's the idea behind that. And I think it's worth it for PNHP to consider that, so long as the prize, the eyes on the prize, is the state-run system, everybody in, nobody out, simplified administration, et cetera. But in the route to get there, there are some things we can do to make life better for people immediately on the way to that.
Sherry, having just retired from general internal medicine at Jefferson, which is a public, it's a critical access hospital. So we took all comers, addiction patients from, birth to death. It's interesting you say that, because one of the things that has come up in the last 5 years in general internal medicine is the egregious behavior of the private insurer Medicare secondaries, the so-called, what am I thinking
Medigap?
of? Huh?
Medigap?
Yeah, they're not Medigap though. They're the ones where you basically buy into, it'll come to me in a minute. I'm having a senior.
Oh, Medicare Advantage?
The Advantage plans, yes, because as you all probably know, the Advantage plans, when the ACA was initiated, are not subject to the restrictions on pre-existing diseases. They can do whatever they damn well please. And we have certainly seen that in senior healthcare up the wazoo, especially in the last 5 or 6 years, once they got more confident and got those federal dollars in, and having practiced first in Nevada, which is almost completely controlled by universal healthcare. It was a terrible environment for private insurance down there.
You mean United Healthcare?
I mean United Healthcare, yeah. Universal Healthcare controls the hospital system. United Healthcare controlled, when I left there in 2017, 80% of the insurance market in Nevada. And it's not much better now from what I understand, but one of the things that the state of Washington could do, just as you said, as part of this incremental thing, would be to crack down on what Advantage plans for Medicare they allow into the state and how they allow them to operate. Because those Advantage plans cover everything. They cover durable medical equipment, they cover behavioral health care, they cover drugs, they cover everything. So as a way of incrementally showing the general public how much better it would be not to let Wall Street and the markets control their healthcare, because patients are noticing. They wonder why all of a sudden they can't get their, $10,000 a month drug for their psoriatic arthritis when they could a month ago, and it's just completely at the whim of the insurer. So I did not realize that Washington was working that strongly on a statewide program. That would be wonderful.
You remember, Sherry, some years ago at one of our board meetings, I brought up the idea of a Western consortium for single payer to include Washington, Oregon, and California, minimally, maybe some others. And California is the 6th largest economy in the world. So if we could set up some interactive system of funding it, we had a problem because we have no income tax in the state of Washington. There might be other ways to contribute to the funding. But that might be a nice model still for demonstrating the great advantages of a single payer system, and particularly the fiscal advantages of it. I don't know whether that's still viable or possible. You still have to get this problem of getting a waiver from the federal government, particularly for Medicare. But if we have a new administration, they may be more sympathetic to that. That's possible. I don't know. What do you think of it, Sherry?
Well, it is included as a possibility to be considered by the work group, but they're not spending a lot of time on it. I think one of the things is simply the funding is so difficult to deal with when the 3 states, or at least our state, is so different in its taxation system than the other 2. Makes it very difficult to raise funds in our state for even if we got all the federal money, you're simply going to have a payroll tax, and you're going to have some kind of an individual premium. You can't make it an income tax. It's going to have to be a premium, and you can step it to some extent. Mostly you can exempt people below a certain level. But we wrestled with all of this 20 years ago when we wrote the Washington Health Security Trust legislation, is how do you fund it without running afoul of our state's total allergic reaction to an income tax, which
I think
by 2 to 1 every time it's on the ballot.
this is Hugh. Sorry, I jumped in early. I was at another meeting, but I don't know if any of you saw the United Nurses presentation yesterday online, and in consortium with the California Nurses Association, which is a very progressive group. And I know that through other friend of David and I's, Bill Bronson, they've got a proposal on the table to reform the California system. I was in Sacramento visiting with him, and I was embarrassed by how well the UC Sacramento Medical Center was built and developed with basically tax funds compared to what we have to scrounge together, again, because of our regressive tax strategies. But I think we should capitalize on the political momentum. I think the nurses are totally with us. Surveys are showing that 70% of the American people are with us. And in the recent election, all of the US representatives running for re-election who supported single payer won, and those that did not lost. So, you look back historically in terms of where this stuff came from, and I appreciate Saskatchewan did it in Canada, province by province. But also, I don't know if you all know, but the UK system came about in World War II, during the Battle of Britain, where people were getting hurt during the bombings in the cities, and they said, well, what hospital do we go to if we get hurt? They said, go to the closest one. We'll take care of it and we'll cover you. So I think, chaos is opportunity. And I think you know, obviously we're saddled with this horribly regressive tax system in this state, but I think we need to keep the pressure on, and we need to unite forces with groups like the California Nurses Association, who we've had present at previous annual meetings, and the Nurses United, which I was very impressed with the quality of their speakers last night. People were extremely well informed, up to date, and they really, and there, you know, there's I don't know the numbers, but I suspect there's more nurses in this country than there are doctors, and they are really on the forefront and taking this right in the face. And that, you know, this horribly dysfunctional administration that we've just suffered through, you know, hopefully we'll get some traction. And obviously we've been handed a very conservative Democratic administration to deal with, but we need to enlist the Bernie people, the nurses, and everything to put the severe pressure on Biden to do something, because this is an extremely unprecedented calamity that's befallen our country.
I think you need the money people.
Well, you know, it's interesting.
Million people who voted for Trump, and I think Sherry's comment, I think our girl Elizabeth Warren, who's very good at crunching the numbers, because that's really, for most patients, they want to stay with their own doctors in their own town, in their own comfort zone, and somebody needs to convince them it's not going to cost them, you know, it needs to explain to them why in the long run it won't cost them more.
Well, I think that's why PNHP's primary mission of public education is really important.
Yeah.
Through PNHP, locally, the Backbone Campaign, United Nurses, we need to get that message out to people and get it to them strong. Because as the pandemic affects the economy, and employer-based healthcare insurance is shrinking drastically, and we all know disasters. You talk about addiction and mental health. I can tell you, in the city with top shelf coverage, it's a 3-week wait to see a psychiatrist for an acute crisis. And these are members of my family that I've, as an insider, have tried to access care. So mental health care, addiction care in this country, I think is a fraction of what it needs to be. So I think we need drastic change, and I think we just need to keep the pressure on all fronts. And this is a unique opportunity fostered by this horrible pandemic.
Yeah, I think that I focus very strongly on the tremendous power of preventive medicine. And if we have a single payer system, particularly multi-generational, we can make tremendous gains on population-based epidemiology. We could ask questions about intergenerational and multi-generational inheritance of environmental perturbations during pregnancy, because there's growing evidence that not only is there an impact on the somatic cells of the environmental agent in the little fetus, but on his tiny little or her tiny little germline. And that could change the epigenome and could produce substantial kind of susceptibilities to age-related disorders and other disorders as a result of the epigenetic changes. And if we have the kind of multi-generational data, we can really dig into that. I have a colleague at the Western Washington University who is looking at what's very common in his part of the Eastern Washington state of an agricultural pesticide. And he works with a model of rats, and he gives the pregnant rats early on various doses of this common pesticide. And guess what? They, generation after generation, think of the rats, the children, the grandchildren, and so on. They all show one is a kind of a classical hallmark of the biology of aging, which is a dysfunctional protection of your genome. There's more and more genomic instability in the children and the great children and the great great children of that rat that was that was exposed to an environmental agricultural pesticide being used by agricultural workers today in Eastern Washington and elsewhere. I think that's where the future is. I think in preventive medicine, that's what we have to really gig up. And I'd love to see more support for schools of preventive medicine and for more research. And my God, if you have a multi-generational kind of single payer system, you really have a great jump start to find out what's going on.
Well, should we go back to the annual meeting and pick up on some of the themes there? I think one of them was state versus single versus national work. We've covered it a little bit, but I could show you a video snippet that goes into it in more detail. Throughout the board meeting on Sunday, and also PNHP is going to change its mission statement somewhat to show the movement towards working with other social justice groups, working in concert with them, the implication of intersectionality, that a lot of these social justice groups, issues are tied together in different ways, and that if we can get the silos working on a specific social justice issue to be torn down, to work together to create a movement of movements and a web that the web marches forward and everybody comes with it and is being pushed in front of it. So anyway, those two concepts of working with other groups, and I think the mission statement will be probably blasted out soon, but that's the theme. And at the state level, a lot of state chapters are working pretty closely with other groups, such as we are here with the Healthcare as a Human Right group and Healthcare for All Washington and Washington Physicians for Social Responsibility, and we're trying to, and Community Action Network. Anyway, we could talk about that, or state versus national. I know that's something that Jim Squire, is he still here? He's always.
I think he's given up on us.
What? I think Jim has a pretty lousy internet connection basically from where he lives. Then, the final thing was, where do we go now under in the new Biden administration and with a gridlock Senate? What should be our approach there? So anybody want to talk about, see if I can pull up some snippets of from that panel?
Please do, David.
Pardon me?
Please do that. Do.
Which one?
State versus national.
Okay. So hopefully I won't have any problem turning it off this time. And it's 1633. Let's see. Hopefully it'll come up here soon.
One of our big priorities as well going forward.
So one of the questions is, PNHP's primary mission has been to organize doctors around single payer. Oops. And is this the right time to focus on our individual energy and activism more broadly, or should we stay laser focused on physicians and patients?
I think it's important to still focus on physicians, because physicians are often accused of being the problem. We're the ones that make all the money, and this is why healthcare costs so much, which the data does not bear out at all. And it's the physicians who have to deal on a personal level with patients who are not able to adequately access the care that is clearly needed. So I think that if physicians really understood what the issue was, and especially the subspecialists who have been more resistant to Medicare for all than primary care physicians, that we still need to focus on educating this group so that they understand the need.
Sure. So I agree that I think the power of PNHP and SNAP is the focus on health professionals and physicians and medical students. But I do think this is a time for us to continue to be focused on Medicare for all, but understand how intertwined this issue is with all of the other issues that we have known exist in society for a while, but are bubbling up to the surface. As Susan mentioned, the issue of equality and systemic racism, and even things like climate change, they are very intertwined. And I think it's going to take a multi-issue coalition to start seeing the changes that we need to prioritize people over profits, because that's what a lot of these issues boil down to. And I think health professionals have a really powerful role, not just in the Medicare for All movement, but in all of those other movements. So that doesn't mean we have to shift our focus away from Medicare for All, but be willing to work with these other movements to lift each other up as we kind of lift ourselves up. Because I think it's a big moment for all of these issues that have been just festering for decades in this country.
I think that's an important point. And physicians can play an important role of advocates. Somehow having those initials after your name make you a very powerful advocate. But Adam, I'm going to ask you another variation of this. We've seen lots of success in the last 18 months of pushing medical societies to either embrace single payer or to soften their opposition. What about the strategic analysis of movements for single payer at the state and state level versus the national level? So, where people should feel they'll be most successful in putting their efforts and energy.
I'm happy to take a stab at that one. So, this is a question that I think has been debated within the single payer community. I don't know how long, but I'm guessing for as long as you've been in it.
Yes.
I have a fairly, I would say, balanced sort of perspective on it. So, look, there's no question that the state level movements have been very successful, in particular at galvanizing support, acquainting people with Medicare for All, and oftentimes giving them something to do in terms of activism, in terms of canvassing and other activities. So, we saw this certainly in Vermont, we saw this in California, and obviously those both failed, but I think a lot came out of that. Despite that. In fact, I know a lot of people, for instance, in California, not so much, maybe not just in PNHP, but in other groups, were first acquainted with single payer through their activism in that California single payer campaign. And who knows what will be achieved first and what can be achieved. I don't have, none of us have a crystal ball in terms of where we'll first have success. But I think we should also, acknowledge that state-based efforts have weaknesses as well, and these have been discussed over many years. But for one thing, first off, we know that we definitely need federal executive action to allow a state single-payer bill to be implemented, to allow the waivers and all that. And we probably need federal legislative action. So it's not as though a state-based campaign gets around the need to sort of have national level victories. We also know that we don't want to leave states out. We don't want to leave conservative states out. We don't want to leave states in the South out. And that ultimately we all agree that the national plan is what the country needs. So I think we can have both of these kinds of efforts proceeding in parallel. I first got involved in PNHP in New York and went up to Albany for lobbying day, and that was a formative experience for me. So those are just a couple of perspectives. I don't think we need to have an either or approach.
We couldn't even get all states to expand Medicaid. So that I don't think that initiating individual single payer programs by state will necessarily create a movement so that all 50 states are part of single payer. I think that because of the structural racism and the inequities that are just innate in this country, there will be some states that will always not agree or want to buy into this type of system. And unless there is a federal mandate or there's something that will require them to do that, because their resistance to Medicaid expansion was not based on cost. They clearly saved money by providing more care, but they still chose not to do that, which I think their action says a lot about what their feeling is about providing health care to everyone who lives in their state. So I think it really, in order for this to expand to all 50 states and be a national program, it has to start at the top.
Well, yeah, I think there's something to that. But I will remind you from a historical point of view that Medicare for All, Medicare, which is what Canada refers to their plan. So we borrowed the name from them. And it started in the province of Saskatchewan. And what happened is that Saskatchewan saved so much money, and physicians' income went up because they now got paid for all the care they provided instead of just paid by those who could afford it, that within a few years, the other provinces said, hey, we want what they want. And as a part of a national movement, then they crafted a bill that was, only 8 pages long. And provided them with their Medicare. So I think that there are opportunities to help people organize on a state level, but ultimately will only be successful and achieve the savings on a national level.
I would just like to add really quick. So I agree with Adam's point that I think state and federal, it doesn't have to be competing interests. Right. And Susan, your point about Medicaid in expansion is really what I kind of think of it as. And I think if it were to start on a state level, I would hope that 1 or 2 states would pass it and it would go first, almost like a pilot, to kind of calm other people's fears so that we could get over that hump of being able to pass it federally. So I agree with you. I think it would take forever if we ever got all 50 states individually to set up a single payer plan. But in my dream world, if single payer did start on a state level, let's say we'd have a New York and a California that pass it, it goes really well for a few years, and then our argument gets so much stronger that we need this on the national level, and then it becomes a national program. So
and that's exactly what happened in Canada. Couldn't we have people?
Okay. You want to comment on that? Do we have sound back?
Yeah.
Yep.
Shulamit?
It seems to me that the debate I've heard it in previous years. It seems to be a coming together of saying one does not exclude the other, and emphasizing that we gain interest and widespread ideas through the state level, but ultimately it's going to be national. And that's no longer a matter for debate about that the two can and will work together. Whereas in prior years, there was talk about one will undercut the other, that one people approaching from the one direction would undercut those from the other direction. I don't.
You're
Cutting out the sound, Shulamit.
Can you hear better now?
yes.
Oh, sorry. So with this COVID, the experience we're having with this COVID, that it's becoming very real about having some things happening at the national level and being blocked by some of the states. We can look ahead and see this as the process that's likely to go forward. And I think it's much better now that we're no longer kind of fighting on this issue. And if that seems to be the case national, so maybe that can happen for us too in Washington.
Well, I think, Shulamit, that's such a great, you said earlier, anthropology and medical policy are not the same, but that's the bottom line is COVID-19 doesn't care if you're African-American, white, Native American, disabled, gay, transgender, it doesn't care. So we have this one huge national unifying factor that crosses all boundaries. So as they work on rolling out what is obviously going to be a massive new retooling of our public health network to get this handled, this is a great time to say, look, you know, if we had a national health program, a national health insurance program, any kind of national health care program, you know, just get the idea into everybody's heads. For the first time in a generation or more, well, obviously 40 years really, that could be the skein that brings everything together, because it's not just about any one demographic group.
So Merle, did you raised your hand?
Yeah, can you hear me?
Yep.
Yes.
You can? I would have 3 points. The Canadian model, I don't think really pertains to the current Wall Streetification of the entire world. They didn't have that in Canada at that time. And I, with the group called Public Banking Institute, or with Seattle Public Banking, and we've been trying to get the city out of the too big to fail banks, or whatever you want to describe them as, with the added advantage of your infrastructure aims would be covered by the interest that you ordinarily would be paying out to the banks would directly go into a revenue flow of your either your state or city. And I'd like Sherry, I don't know, I mean, you could almost go independently, financially wise, perhaps, if you were to rely on a source of funds that would be, let's call them a little bit on the edge, so to speak. I know we fired Wells Fargo for this city, but we couldn't get anybody to take up a public bank. Maybe if there was enough willingness to dedicate it towards something we all could benefit from, which would be healthcare, might make a difference. But I wanted to ask Sherry, you know, in the San Francisco case, they were getting, you know, their judges ruled that, you know, for Healthy San Francisco, that the funds would still accrue to the city that were, let's see here, possibly being not in line to actually go to the city. And so the courts ruled in that case that any funding to the city, which, you know, has a universal system, would be overruled, so to speak, or at least we have that model for that happening. Could Sherry comment on that?
Well, I would have to know a whole lot more about the legal case, in which case I'd talk to my husband, who would give me off the cuff interpretation, because as a retired federal judge, he doesn't give public opinions. But there are a lot of things that are under federal control that bring a ton of money into our state. For example, Medicare. And Medicare's money is very tightly controlled by the actually Congress. And it's the one thing that would require act of Congress to change the way Medicare's funds come into our state. So it's, I'm not so sure that we could get a friendly interpretation of all of these funds coming into our state. And I don't know how much of the monetary pie the legal opinion in San Francisco covered. So if it covered just Medicaid, for example, that's still very helpful, but it doesn't cover everything. So I don't know what would work. The bottom line is you got to have federal cooperation in order for the state to get the money. It's probably somewhere in the neighborhood of $80 billion a year, the cost of the entire current expenditures in our state on healthcare. Now, there are savings to be had, of course, if we have the state as a 1,600-pound gorilla negotiating prices so that we don't have to pay full prices, and so those prices don't become our costs. But it's still an awful lot of money. And I think about half of it comes from the federal government.
You know, Sherry,
That might not.
I wonder if we should be focusing on that parameter of the enormous reductions of the costs of healthcare to the nation. I know the kind of right-wing guys are very concerned with the budget deficit, all the conservative guys. And if we push hard with all the hard data about the enormous amounts of savings we could do on the budget, that might be a way to get a handle on them, to come over to our side a bit and some kind of compromise. I think that's the only thing that would move them. And it's, gosh, it's right now with the evidence of the change of the demographic proportions of older people in modern societies. Right now, it's increasing enormously, the proportion of older people to have tremendous health care. So right now, what is the GDP for healthcare is of the order of about 19th percentile. There's some estimates that by 2050, it goes up to 30% of the GDP. So it becomes an enormous important parameter, costs. And if we push hard on that, there might be some weakening of the opposition to, oh my God, this is socialism, single payer.
Well, one of the ways to get at that is transparency. And there are some laws cooking around requiring transparency. Now you need transparency both of prices and of costs. This is particularly important when you're dealing with a hospital. Not just what are their charge master prices up here, but what is it actually costing them to deliver the care. And the difference is right now enormous. And so they're stashing away huge amounts of profits that they don't know what to do with, because most of them are not-for-profit hospitals. But the transparency is how you can really get the public behind you when they see how these folks are ripping us all off by making people, by dealing with their prices rather than with their actual costs. And of course, that is also one of the major differences between the social service model of healthcare, where it's a government responsibility, and they look to, okay, what does it cost? And we will allocate enough money to cover those costs comfortably. And the idea of prices kind of goes out the window. But in our business-oriented model, it's like you walk into a store and everything has a price tag on it, and you don't know how that price tag relates to what it actually cost the merchant to buy and stock the item that you're looking at. Sometimes you can bargain the price down, and sometimes you can't. But that's where we are here with prices and costs. And I've just written a whole essay on that subject that I'm sending off to the folks who are managing the universal healthcare work group process, that we really need to be careful about when we talk about prices and when we talk about costs.
That was some amazing data that came out in the last few days too about particularly HCA, how their price to cost ratio was inordinately high. I mean, it was over 10 to 1. And, you know, as all of those of us who have experience in healthcare, I can barely interpret my bills.
How
What
do
the
you
upfront,
think that Senator Frist paid for his campaigns? That's his family's money, right?
that's right, exactly. Fritz and Abbott too was one of the CEOs at HCA before he became governor of Texas. So, I mean, the information that people are fed is such a small, coned down version of reality. And if you go a little bit broader in some of the more open and public liberal media, and all you have to do is look these guys up on Google and all that data is there. But it is astounding.
So Mark, you had a point?
Yeah, as I've been listening, and I would simply play back the stuff that resonates for me that I think has a strong communications possibility. I really like the notion of pressure on all fronts, which Hugh talked about, given the traction that they have in California and so forth. I think we should take traction wherever we find it and enjoy it and support it. And we know what the gold standard is. And I think actually the opportunity in the near term, though, is to focus on the crater that's going to be left behind by COVID and the national opportunity with the incoming administration. And perhaps that can work where we look at this once in a lifetime inflection point and throw everything we've got behind that. And if it doesn't work, then maybe shift and support. Well, I think we should just give endorsement and support with maybe perhaps without spending too much of our energy and resources to all of those other efforts that are going on as we really try to get behind the gold standard, eyes on the prize, as you say. I think that there's this, what's happening nationally now, I've never seen anything like it. And I think it's, I had not ever expected something like this to happen in my lifetime. I thought, you know, single payer might come about, or national health care of some kind might come about after a war. Luckily, we haven't had a war, or a Great Depression. We haven't had quite one of those, but now we've got a pandemic. And the last time I looked at all of this was 5 years ago when I made that video. And there I straddled it in a similar way. I said, the right way to do this would be Medicare for all on a national level. But if you can't get that, get what you can, which was at the time traction in Washington. But it's great hearing about what's going on in California. I think they're actually the 5th largest economy. I'm not, is it 6th or 5th? I'm not sure.
Right. Uh-huh. Could be.
Yep.
That's mighty big stuff. I mean, I injured myself in Iceland. I broke a finger and I got stitches and all of that. And, you know, that was a couple of years ago. 350,000 people in Iceland, and they pull off universal health care. My God. Okay, I'm finished. Thank you.
Maybe we should watch our last topic here, the path forward, where we go from here, given the, you know, the Biden administration and so on. So let me share the screen for that last bit from the panel at PNHP National.
We're supposed to be talking about the path forward. And if each of you could take a couple of minutes to talk about what you think is an important approach for the coming year as we figure out how we're going to go forward with the Biden administration that has said that they would support a public option, but not a Medicare for all. And I'll start with Rachel. And
Sure. So I think building our grassroots and our membership is going to be very, very important in these next few years as it has been in the past. And I think COVID-19 makes that even more important now, because we are seeing so many people in record numbers losing health insurance, losing their jobs, and not really knowing that Medicare for All could help ease that burden. It obviously wouldn't solve all of the issues of COVID-19, but the pandemic has made our responsibility to fight for Medicare for All so much larger. And so we need to keep meeting people where they are. If it's a patient who has had a terrible experience, getting their story. If it's a provider who is just burnt out from the private health system, getting their story, getting people to join in our movement, and really having those longer, in-depth conversations of not just Medicare for All is great, but understanding why it would help them in their situation. And I think if we build a large enough movement, and someone mentioned it before, but I don't remember, the politicians usually love to be in front of a parade, right? So we have to make it politically impossible for them to be against Medicare for All. And I think these 4 years is when we do that work. So it's probably virtual right now, but that doesn't mean that you can't be talking to people, getting the word out, writing articles. I think we need to build that movement so that if it happens under a Biden administration, great. But if not, when the next administration comes in, they cannot ignore Medicare for All. It has to happen.
Great. Susan.
Okay, I think it's important that when we look at the need for healthcare and providing adequate access and resources, it's all a part of all the social justice issues that are going on now, and to become engaged with those fights, because having access to healthcare is not going to solve your medical problems if you are still housing and food. Your resources are still limited. So that all has to be put together, and I think that there is power within the numbers all involved with these related issues, and that to look at this as just another part of the social justice issues, another part of all of these social justice issues that are being made visible and worked on now, and that if we join these and become part of that group, there's increased power with numbers, and that it's another way also to get our message out and through the people who will benefit and who can produce the changes.
Okay, Adam, you've got the battle scars for the last couple of years and as our fearless leader, so I'm going to let you.
My recommendation, I mean, look, I wish that I had a perfect strategic plan that was on the back wall here, where it was a bunch of diagrams showing how we get from here to there. And if I had that, I would share it and we could do this. The reality is no one has a battle plan that exactly shows how we get from here to there. But we know what the kinds of things we have to do. And it's the kinds of base building and grassroots organizing that Rachel spoke about. It's the intersecting with other social movements that Susan referred to. And I think I would just close with this point. If we wait for the opportune political moment, if we wait for the perfect Congress and the perfect president, first of all, it will never happen. But second of all, even if it did, it would be too late. The only way we're going to pass Medicare for All is to push, and make the politicians follow, as Rachel said. Get that parade started so you can put them at the head of the parade at the last moment, and they can take credit for it and get their name on it or whatever they want. And then that political window opens, something shifts, something changes, and then you win. But if we wait for the window to open, we're never going to get through it, because we will not have been prepared.
Thank you all very much. And yes, I'm a big advocate of that. The politicians have never led any movement for social justice, but I believe that they like to be at the front of the parade. And so that's what we have to do, is we create a groundswell, and have my battle wounds from a number of social justice issues. I know that's how it works.
Okay, so everybody knows what to do now, right?
All right.
I'll meet you outside tomorrow.
Question.
Hey, guys, go ahead.
Since I'm new, what is Western Washington PHP doing? What pre-COVID, obviously? I mean, do you guys do public speaking? Do you
Yes.
have community outreach? Did you have a game plan before we all kind of got downsized?
Well, many years ago, we actually started the Healthcare as a Human Right Washington Coalition, which is pretty big now. You know, it's got 20 really active organizations and 80 that have signed on. I can't say that we're leading it now, but it's very active. It's got a whole lot of legislators that follow it. It organizes things in the state legislature. It's involved in the working group that Sherry's a member of. So that's one thing. We have these monthly meetings, and we have a website where we put the monthly meetings and some other things. And we try to keep everybody in touch with opportunities to become parts or go to meetings for that other progressive groups in the healthcare advocacy field are putting on. So, you know, I wish we were more active as far as younger physicians that are now working. Most of us are retired, I'd say 99%. There is a SNAP chapter at UW that sort of associated with us. We helped get it going, but I think it's really hard for medical students to keep focused because they're spread around the state and they're, you know, internships, and they've got families and they got a whole lot of work going on in their medical school residency programs. So we're lacking in that we have physicians that are active now, still have practices, and you know, we could do a little better or quite a bit better in you know, diversity as far as different people of color in our organization.
So actually, David and Sarah, I think one of the significant aspects of why we helped initiate a SNAP chapter at the University of Washington, Students for the National Health Program, is that a large proportion of them are actually pre-medical students. And we're trying desperately to get more representation from other academic domains. For example, the School of Law and economics that also have multiple other disciplines that have relevance to the importance of Medicare for all. And it's a modest progression in that direction. I mean, we've got a lot of interest in the School of Public Health. And we wanted to really, not just the medical school, the dental school and the public health in particular is important. But I think that's been an important addition, and we have usually officers there that come to our board meeting. Lately, it hasn't been too successful, but in the past it has, and we want to do it again. So they're not all medical students, and I think that's good. We want a broad representation of the campus in multiple disciplines.
We also
Well,
try
I
to
think
get involved with direct actions when we can. You know, most of the May Day parades and Martin Luther King things, we've been out in the streets carrying our banner.
we've done that. We've also done workshops when workshops were done as part of Martin Luther King Day, that we would host a workshop. We've also had annual public meetings that attracted 100 or more people that were held at the university. And we held off this year because we were waiting for the election, really, because things were just sort of paralyzed with as unfriendly an administration as we had. And then, of course, the pandemic hit and everything has gone into a cocked hat. So we're mostly talking to one another once a month at our board meetings, and once a month in addition at these meetings, the general membership meetings, and trying to keep everybody's spirits up and wait for opportunities to do more. For example, trying to revitalize the SNAP chapter by attracting more undergraduate pre-professional students is difficult when they're all working from home. We'll put it that way.
And we're also having initiatives to try to get Eastern Washington involved in Western Washington with an ultimate goal of changing the name from PNHPWW to PNHPWA for Washington, all Washington State.
So there's two chapters in Washington State right now.
No.
This is one, but we want to get the Western Washington folks, and there's some in Spokane area in particular that are enthusiastic. And we're reaching out. Sherry's done some good work at reaching out to them. We've got to do more. So I think.
I apologize, I don't get it. There's PNHP Washington.
It's WW, where the name of our chapter is PNHP Western Washington.
But does that cover the whole state?
No,
No.
it doesn't.
That's what I'm trying to get at. So how many chapters are there in the state of Washington?
No, we're it.
That's us.
We're the only chapter,
No.
but we're focused on Western Washington, and we've got to do more work.
I get it.
We know that there are folks in Eastern Washington who are in the medical profession who are eager for single payer, and we've got to unify together and make a larger organization that involves physicians from all over the state. So that's part of our,
Especially with no
our long-range
travel time.
strategic plan.
The
Zoom meetings really bring people together.
The national
Yes,
organization has a
They
so-called
do.
inland Washington chapter, which was semi-active for a few months several years ago. But if you look at the PNHP national website, it still lists 2 chapters in Washington State. But really, there's only ever been one, and we started in 2005. But we have people on our blast list that are outside of Western Washington, so they're welcome.
And you have a lot of friends in Oregon too, the Mattisell doctors.
Yeah, we have. Anybody can join our meetings, that's for sure.
But isn't that just the
Thank
Washington way?
Well, we used to meet in person, before the pandemic. So it was pretty hard for people, an hour or 2 hours away to drive into Seattle to Swedish Cherry Hill Hospital where we had our meetings. So we got.
Can I ask one more question then? Because I do have to go. So let me just I did some public speaking and some public writing in Nevada for the chapter down there. Not a lot, but some. And as I said, I helped set up and establish the first clinic for people without health insurance in Clark County, which is where Las Vegas is, which at the time Nevada led the country in uninsured, and with 500,000 plus people in this state that were uninsured before the Affordable Care Act kicked in. So now that I am just recently retired after 38 plus years of primary care internal medicine, if there is something that I can do, this is my thing. I am on the ACP Washington Policy and Executive Committee, Policy and Ethics Committee, which meets tomorrow night, and I'm just getting involved in that because, again, I've only been here 3 years and I've been working. But I would, if anybody, David, you've got my email. I think the time is now electronically to do this. Mm-hmm. It's going to be a year easily before we're going to be meeting people and getting together in person, and that's a year wasted.
Well, there are some other people in your area that are known single payer people, like, do you know Matt Reddy? Mm-mm. He's on the hospital commission there.
In Port Townsend?
Yeah. And there's another doctor there who just retired who did some research and, shared it with us. So he's on a mailing list. I forget his name right now. but I could look it up and let you know.
I'd be interested to know, I've only been here, I came here to finish my career so that my husband could pay for his boat improvements. So he's on a budget now. But yeah.
That's good ambition.
I have to,
Did you guys hear?
Glad to have your participation.
Did you hear Trump say Medicare for all at the debates?
No,
He
I just
kind of
listened
stepped
to-
back. He said, they're going to be asking for Medicare for all. He stepped back. That was the only time in the whole campaign I heard it. Was him when he, so, any news is good news, or any ads, or any,
Gotcha.
Oh, well, yeah, I just wanted to say that, can you hear me?
Yeah.
Okay, just wanted to say that from what we would be contributing if people would get more connectivity and even intersectionality that you were describing, is that when you do have an effort to do something, it's welcome to know what the personal persuasions of people that we interact with are. Like I've been to different panels that were discussing those issues, and some of the people who you bump into here in this group will pop off very interestingly, and then you'd at least have an idea of where they're coming from because you've talked to them before. But I do, when we're gathering signatures for initiatives, it's very important to have a script, and that script can be developed in a fashion which I think this group helps you to construct. And so I think there's a lot you can do just by interacting and lead ups to actual efforts for initiatives such as I believe it was 1260 here this last time they put it forward. But I welcome those people who do come forward and have panels and more or less a airing of issues with the politicians that seem to be very positive. It really stimulates the whole process of trying to get something on the ballot.
Well, I just really want to welcome Sarah and hang in there and stay with us.
I will.
Yeah.
I don't know if you caught my personal story, but I am the proud mother of a 31-year-old with cerebral palsy. My family story with his dad is that my entire income went to his health care because he was uninsurable.
That reminds me, I just saw a terrific movie on Netflix last night that I was referred to called Crip Camp. Have you heard
What
of
is it called again?
I can't watch it 'cause
Crip Camp. It's about the whole disabilities movement from, almost its beginning to, through the years, and all the tremendous fight they put off, and all over the place. It's really a heartwarming, really engaging, invigorating.
I can't watch the movies. I think I've heard, I took care of a lot of disabled patients as an internist in Clark County, because Nevada was just such a hostile environment to anyone who wasn't rich or wasn't real poor, and didn't qualify for Medicare or Medicaid, because prior to 2010 you couldn't just get on Medicaid, and yet it was everybody from Southern California who was disabled moved to Las Vegas because of the weather and the climate, and it was a mess with a capital M until the Affordable Care Act kicked in.
This shows how the organizing brought all these differently abled folks together and how they won and all the battles they fought. It's really a documentary that I think we all should see, because,
But that does bring up another point. The bubbling up of the issue of racism in medicine is something that many of us are not surprised about, but we didn't quite understand its depth.
Yeah.
Or as exactly what it felt like or feels like to be a doctor while Black. And I thought that Dr. Rhea Boyd, and you can probably find her talk on PNHP's website to play it. That and then the book that I'm reading, but I'm not all the way through. My husband has read it all the way through, Cast by
my nightstand. I haven't started it yet.
Wilkerson. I've forgotten her first name right now.
Isabel.
But
Yeah.
both of these, and the talk that was given at Healthcare for All Washington's annual meeting by Dr. Ben Danielson, who is a pediatrician at Odessa Brown. And Sarah, you might not realize, but Odessa Brown Clinic is in what used to be the major Black part of Seattle. And it was founded by people from children who were trying to set up a clinic to serve the needs of the people in that community. And it still does serve minorities and especially people of color, even though the neighborhood has gentrified quite a bit right around it. But Ben Danielson is a pediatrician who happens to be Black, and he talked about his experience, but more about the general issue. Whereas, well, anyway, it's just all brought it home to me so much more about what it is. And of course, it's brought back memories of about around the time I was in medical school, that being a medical student while female was a problem. And I felt it in various ways. And since then, I know of people who have problems being physicians while Black, trying to drive home at night in Seattle suburbs and being stopped numerous times by the police, even though he's lived there for years. That kind of thing. So I would recommend delving into this more. Read Cast, go on PNHP.org and find Rhea, her last name was Boyd, I think that's it. I would strongly recommend that all of us who have lived lives as white know this exists, but we don't know it in our bones the way you will after reading this. And we need to deal with that as well. I still think, I like the saying, I've modified my saying a little bit. We need to, what PNHP wants to do is bring everybody into the tent, and then together we can improve the tent. And so, you know, covering everybody, you know, single payer doesn't solve all of our problems, but it's a start. But we then have to work with everybody to keep going and improve the system. And that includes healthcare, that even though covering everybody would make healthcare equal, it doesn't solve everything. There's still a lot of systemic. I think what Dr. Rhea said the most was how the effects of living under constant stress, of never feeling safe, affects people's health long-term. Higher blood pressure, higher rate of diabetes and the like are a large part related to this constant stress. And it's hard for us to get a handle on what that must feel like.
Okay, so I'm gonna 5, 4, 3, 2, 1. 5.
Blast off.
Bye.
Thanks.
1. Bye-bye.